None of it.
Oh, that's a good one. I like that. That's a good one. Who else liked that joke? That was pretty good.
Positive thing, because Nunavut is doing fantastic.
Yeah.
They have no cases.
They got no cases. Territories are pretty good for the most part, but yeah, some parts are concerning though, right?
I imagine.
I think so. We're just waiting for a few people on Zoom. Daniel Schultz requests. Well, Dan wants to be live for shin splints. Been a while since I've seen Dan's face, but you can cancel it if it was a mistake, Dan, but would love to see you. So Zoom wise, I don't know. So it's the same link for Zoom. So whoever wants to go on Zoom, it's the same link as before. I do have more poetry prepared for today. Did you hear about that yesterday?
No, I must have jumped on the feed after the poetry.
I'm going to be writing poetry every day about physiotherapy. So the segment's called Physiotherapy and Poetry. So I think it's interesting. I like writing poetry. Never wrote it about physio before, but I don't know. We'll see how it goes. Today's migraines and headaches. That was a request. Yeah.
Let's see what you got.
I wrote it down. It's at the front desk.
Oh.
I could run.
Sure, yeah.
It will be posted today anyway, so if you follow us, you will see a post on it.
That's good enough for me.
Maybe we'll do it at the end when there's more people that attend. Okay, we got some more people. Dan says hi. Hello, Dan. Hello, everyone. Shahad. Jen, I miss you, Jen. This is starting to add up, this whole social distancing now. I think it's getting to me a little bit. I don't know what to say about that. I don't know where I was going with that. I think it's challenging to be away from people. As a physio, we have no like personal bubble or like physical bubble, so it's tough. Like not seeing family and stuff like that. Used to that because they're all in Vancouver, but not having interactions with like yourself and Brandon, like the rest of the team, Chelsea, Laura, Jake. It's difficult. It's very difficult. So yeah, Brandon's got an emoji of a brown Santa. Says. Thank you.
Like physical bubbles. Have you seen that like human soccer game where everybody's?
Oh yeah. That sounds pretty good.
That'll be like the new sport of 2020.
That should be
like,
pretty good.
Keeps
yeah,
you 6 feet apart, right?
Yeah, you could spray some sanitizer on it pretty easily.
Watch,
just hose them off.
As long as you don't trade bubbles with people.
I think that we should start that. That could be our next idea.
Summer Olympics will just be globe soccer.
Yeah, globe soccer. It's pretty dangerous though. Holy, I played once and you get wrecked.
You do, eh?
Yeah.
I've never tried it before.
Maybe we should do that when we're open again. We'll do some team bonding. We'll do that and like go to the rage room, throw some axes.
Sounds good, yeah.
So yes, today is plantar fasciitis. So a good topic, I think. It's pretty prevalent. Like it happens quite a bit in the population, which we'll go through in some slides. And it's good. It ties into running a bit. So that's going to be a lot of fun. Let's talk about, have you had this one? I know I assumed last time when we did shin splints, I was like, Rob's had shin splints because he runs. Yeah. And then he said he didn't. And I was like, that's not what I wanted.
I have had a little plantar fascia.
Okay, good.
Yeah.
A little bit. Did it take a while to clear up or?
It's kind of ongoing. Like it's been, but it's very mild.
Okay. So ongoing. That's good.
Yeah.
We'll see what Rob does.
Foot.
Right foot.
Yeah.
Okay. So right foot. Is that your dominant?
I guess so.
When I was running, I guess you're just using both, but
usually
it's going to be interesting because if we have issues, we'll share with you guys what we do, and if anybody else has some unique stuff too, like whether if it's Jen who's on right now, Brooke, Jenna, like Kirsten. If you guys want to join, just like hit the join live, and then we can have you guys on here too. So if you have tips or whatever it is, let us know and request to be live, and I can add you in and can share your input as well. So yeah, it's a good topic. I've had it before for a few months, I think. And a lot of it was footwear. I changed footwear. I think for me, it was when I was working way back at Superstore. I had to get steel toe shoes. And me being me at the time, and still kind of like this, I'm thrifty. So I was like, I'll buy the cheapest shoes I can. And they were like $50 for steel toe boots. And my feet were on fire. And then months and months of that, and those boots finally wore out. Then I'm like, okay, you know what? Let's buy some good boots. And then I spent like a few $100s on boots. No issue. So, and there's also other reasons why it occurs or can occur. So we'll go into that as well. And again, if anybody wants to go live with us, physios or anybody, let's do it. That's going to be a new thing we're going to do.
I like it.
And then
like open mic.
Yeah, open mic. So it's good because then it like lets us see people and gets more people engaged. So without further ado, plantar fasciitis. I'll let Rob
kick it off.
If you want. So he can kick it off.
Foot kick.
He can put his foot down. I don't know.
Yeah. Put the foot down on plantar fasciitis. That's what we should have called this. Anyways, okay. So plantar fasciitis. So the fascia we know is kind of that like connective tissue in the body. So it's all over the place, including in the bottom of the foot. Feet we can kind of imagine are really like built for stability. Obviously they're kind of a load bearing body part, so they're pretty solid. And the fascia in the foot kind of follows that pattern as well. So compared to other parts of the body, the plantar fascia, like it's pretty thick, it's pretty rigid.
Yes.
Itis we've talked about before is usually going to mean inflammation.
Yeah.
So we talked about like tendinitis being tendon inflammation. So fasciitis is the name is kind of meaning like tendon inflammation. Sorry, fascial inflammation of the fascia.
Yep.
Though like a tendinitis, like often it's a bit more like complex in terms of the real changes going on. So some people will call it like a fasciopathy or fasciosis, those kinds of things, like tendons again. But so fasciitis is fascial inflammation, and then plantar just refers to the bottom of the foot. So that's the name, bottom of the foot, fascia inflammation.
Yeah, it's like quite interesting to see in the cadaver lab when we were there, how thick, how fibrous the tissue was, the connective tissue. So we hear about all these things, and to have it sounds gross, but in your hands, I was going to include some of those pictures, not from our cadaver lab, but from Google Images and stuff. But yeah, it's quite remarkable to see how thick that band is and how stretchy it can be. Yeah,
I think the average plantar fascia is 0.4 centimeters thick at this point,
which is quite
useless information, but in case you were curious.
I don't have a ruler on me, but it's pretty thick for tissue. So
40 mils.
Yeah.
Sort of 4 millimeters. Anyways,
yes. 4 millimeters.
4.
Yes. Correct. I will flip the screen over so you don't have to see my mug. There we go. So boom, plantar fascia.
Plantar fascia. So again, kind of similar to tendons, the cells that make up plantar fascia, they're going to be kind of long, thin cells that are going to follow kind of the long axis of the fascia. So they're going to resist tension. Again, the same way that the cells in our tendons did in a healthy plantar fascia. Here, we'll skip ahead here just for a picture. So the plantar fascia is going to, if you can see my mouse here, it's going to come off of the medial calcaneal tubercle, which is if you're kind of feeling the bottom of your heel bone, it's going to be a little bit more on the big toe side. That's where it's going to come off. And then it runs all the way down through the arch of the foot and sort of attaches down to the joints here at the base of the toes of all 5. Again, more of a technical thing, but it's made up of kind of 3 different portions. So you have kind of a central portion, a more lateral portion that's going to go towards your little toe, and then sort of a medial portion that kind of branches off of the main portion. But again, that's more on the technical side. What else did we have on here? Yeah, so it carries 14% of the total load of the foot, which can be a fair amount of weight. Supports the arch, of course, as you can kind of guess by its position and orientation. And then it acts kind of like a spring during walking as well. So when we talked about running injuries on Friday, for anyone who was there, we kind of talked about like one of the significant stressors on body tissue being energy storage, where it's kind of like basically storing energy and then releasing that energy. So sort of working as like a spring or an elastic in that sense. And the plantar fascia is going to be doing that as well. Oh yeah, here's a picture of that. So this is that medial calcaneal tuberosity. So this is looking kind of from the instep of the foot. So this would be the big toe. And then this is going to be that. A tuberosity is just a bone lump.
Yes.
Everywhere in the body, like any tissue that has kind of load through it is going to adapt to become a little bit bigger and stronger too. Yeah. So lots of like tuberosities will be like attachments of strong tissues like the plantar fascia. And that's kind of one reason that if you've heard of like a heel spur, where that can sort of develop, is that kind of sustained pull from the plantar fascia on the bone will kind of cause the bone to build up there. And then if you look at it on, I think an x-ray is probably the x-ray or MRI would be to kind of see that bone spur on there. So that can be kind of the cause there. Anyways, that's our plantar fascia.
That's plantar fascia. And then medial tubercle is an important point too, because that's like the thinnest part of that fascia too. So typically you have a lot of pain in that area, and we'll show you where that is. Actually, well, I can just show you where that is right now. My foot. So medial tubercle. So kind of in this area, people have, so medial, so this is my big toe, so the inside of my foot. So in this area is where a lot of that plantar fasciitis type of pain comes. Can go into the arch a bit. It can radiate anywhere in the fascia, but typically you get it more so on the inside of the heel and kind of radiates into the arch from what I've seen. Mm-hmm. What about you, Rob?
Yeah, I think definitely that's kind of the most like typical spot for it there. Yeah. Though, like you said, it can exist anywhere, kind of across the stretch.
So I will leave that shoe off for other exercise, but hopefully it doesn't smell too bad. So plantar fasciitis. So like Rob said, inflammation being itis of the plantar fascia. So the thick band is inflamed. Episodes can last longer than 6 months. This is pretty common in people. So an episode doesn't mean like severe debilitating pain for 6 months, but it just means there's an issue. So Rob, for instance, has been quite some time. So you can say he fits into that category. Affects 10 to 15% of the population. So that's quite a huge number when you think about the population, because with this, like we discussed, we have like, it happens with runners. It can happen with people that work in warehouses, AKA me. So a huge population, anyone who's weight bearing, even people who aren't very weight bearing can happen. I've had office workers come in and get treated for this. So I'd say it's like more atraumatic. So it's more of like a repetitive issue. So a lot of these issues happen from increasing activity. That's when we find like shin splints, very similar, that when you ramp up activity, then you can get this issue. So if you're not walking and then walking a lot, you can develop this issue. If you're running a little bit and then running even more, you can develop this issue. So improper footwear is also on there, which I'll show you in the slide. So it's pretty prevalent. So it happens quite often, and it's not too difficult to treat if you treat it aggressively. So 10 to 15% of the population, more than 90% of the cases can be treated conservatively, which means without opening you up, without surgery. So like physio would be one thing. That is a conservative approach. Occurs more often with active individuals. So running is a very common thing. Causes, so loss of ankle dorsiflexion, flat feet, so excessive pronation, so having your feet kind of go inwards with flat arches. Impact weight-bearing activities, prolonged or increased. So I put prolonged or increased, meaning that if you're running for a prolonged period of time, it can occur, or if you're running and you increase your distance, then it can occur as well. So it's a repetitive issue. Improper shoe fit as well, if you don't have enough support, or it's too tight or whatever it might be, can cause that issue as well. Often the cause is multifactorial, so you have multiple things that happen, and treatment, it can be similar in different types of causes too. So yeah, so here is the plantar fasciitis. So this would be clearly where the pain is. It can radiate up into the arch, but mostly it's on the inside of the heel, like I pointed to. And you can see like the fascia does act like a spring. So you can see this big gap. So when you do step, or if you're walking, it does stretch out in mid stance, and then it does store energy. So kind of like a spring, and then you step and release that energy. So helps with ambulation. And here's another one. So you have the heel bone, the calcaneus, you have heel spur, and then inflammation. So that's more of a significant issue when you have a calcification of that area. The main thing is just to show you where it happens and relative to the fascia and where to expect the pain. So a lot of the common things we hear, and this is across the board, is heel pain with the first few steps in the morning. So I always get clients come in and say, hey, the first steps are like excruciating, and then it kind of eases up throughout the day. Or if I sit for a long time and get up suddenly and move around, it gets pretty bad. So you get tenderness along the medial heel, can cause limping due to pain. So if you have heel pain, you're going to avoid that heel strike. So you kind of walk flat-footed or on your toes in more severe cases. And then when you're barefoot, so less protection, you could have more pain too in hard surfaces. So a lot of people have like hardwood at home or tile and they're walking bare feet. It can be pretty painful too. So treatment, and we'll go through this quickly because we're going to show you all this stuff. So treat early. I find if you catch this pretty quick, really easy to treat. I've never had an issue when someone's like, oh yeah, I've only had it for a few days or a week. It's quite easy to self-treat. Active physiotherapy being a lot of education, doing a lot of self-management. So a lot of stuff you can do at home for this, and a lot of exercise and lots of self-care and make it consistent. So being very consistent with this, even when it's pain-free. So just to keep things moving right. Stretch, roll, release. Listen to your body when it comes to increasing activity. So, and we'll talk about that and how to increase activity. So research, I thought I'd share a few things about research. Interesting articles. So one was a systematic review, so a very large study, looking at minimally invasive techniques. So physio, cortisone was in there, PRP injections, that kind of stuff was in minimally invasive techniques versus surgical techniques, or more invasive. And it showed it can be just as effective, if not more effective. So physio was included in that. And then manual therapy, so the therapy that we provide with our hands, shown in one study, so one systematic review, looking at multiple studies, yielded greater improvements from 4 weeks to 6 months. So not only is that short-term benefit, that's long-term benefit. So, and that was manual therapy added to a physio program. So that still included exercises and stretchings, but it compared it to different groups. So it showed manual therapy with all those interventions compared to other combinations of those interventions. Manual therapy always came out with exercise and self-management techniques to have the best results. And then there's another article looking at strengthening intrinsic foot muscles showed to decrease pain and increase in function. So it didn't show like the thickness of the band of the plantar fascia changing at all, but it showed better pain management. So I wanted to show those three articles because that explores a lot of what we do. So one looked at physio being as non-invasive, a conservative treatment approach with a lot of relief. So you don't have to wait for a specialist or something like that to get some relief. The other article, manual therapy. So a key thing, an adjunctive treatment that we do, and we usually get our hands on quite a few people, is very effective. And then we translate that manual therapy and how to do it at home, which for this area, not too difficult. You just have to, give yourself a bit of pain while you do it. And then strengthening. So the intrinsic foot muscle is very important. So showing people that this is an area along with a lot of different parts of the body that can be treated on your own, right? So a lot of it's going to be self-management, like we always go through, common trend. Yeah, so then any questions? Oh, we got one question by the looks of it. I really like your integration of research in these sessions. Yes, thank you. I do. We like it quite a bit. It's not as easy as it looks because we are, and just like Shahad, that you have to analyze research articles. So some you'll see, like if you just Google some, you'll see some and it shows all these great things. Then you look deeper into it and the quality of the research was not good, or their study methods wasn't rigorous. So I think I thank you for that, because it does take some time to find research for this. But the beauty of this is that now we have this humongous resource to give to patients or whoever. So we have all these articles, and now we can just be like, here you go, because they're also new. Like most of these are 2016 or newer, and systematic reviews being a very high quality, like, level of evidence. You could be like, wow, this study looked at thousands of people versus other ones looking at 10 people or one person. So yes, thank you for that. Anything you wanted to add, Rob, to any of that?
Just speaking like anecdotally about my plantar fasciitis. Yeah, it's like, for me, it's always, not always, if I've been doing more running, it'll be first thing in the morning going down the stairs.
Yeah.
It's like a 3 out of 10 pain, and then it's gone. So it is like that first thing, weight bearing in the morning.
Yeah.
Anecdotally speaking, like your slide said, that's exactly how mine presents.
And that's one thing that's like super common. Like you see a lot of injuries and there's a lot of different symptoms that happen, whereas plantar fasciitis is very consistent. Like most people will say they have excruciating, like the first few steps of the day are really painful. And I find that, like, out of all the injuries, this is one that's like, I think it's with everyone that had this issue, that had pain at the beginning of the day or being inactive for prolonged periods of time. So and I think it's an area that's relatively straightforward to treat. You could see that 90% of the cases got better with conservative treatment. So don't have to be worried about, surgery and things like that. I've seen maybe once or twice when it was very severe, but you can be confident that it's something that will go away. The natural recovery of the body will take care of things in a certain sense, but you can expedite the process with physio. We got another question here. In the research, what kind of manual therapy was proven to be effective? So this manual therapy was like massage technique. So like if you've heard of frictioning, that was a main thing of it. So frictioning and then mobilizing the calcaneus and the tarsals as well. So that was the main thing. They didn't like go through the grade of like grade 1, 2, or 3. There was no manipulations, but they didn't go through the grade, or they didn't indicate the grade of manual therapy, but a lot of it was the joint excursion and it was the frictioning. So getting into that area, which we'll show you as well. So that's a good question. Yeah. So sometimes the study methods aren't clearly indicated, but at least they said what type of manual therapy. Sometimes they'll just use manual therapy as an umbrella term and just kind of include whatever in it. So when you look at improving that research study, it would be good to include the parameters of that manual therapy. So what grade was it, and what was the duration of it, right? So good.
Yeah, I think to kind of like set a foundation for the exercises here too. Yeah. Like I think if you think about it as just being like inflammation, the same way that if you kind of think of a tendonitis as just being inflammation, I think the temptation, both for like the person with it and maybe even for like the physio, is to just treat inflammation. So if like, I don't know, ice it, take some Advil, stay off the feet for a couple of days, then getting back into activity. And like a tendonitis, that's often like insufficient for proper rehab. Yes. Because it doesn't kind of build the load back into the tissue again. Yeah. So what you end up with in those cases, I know you talked about how like when you see them earlier on, they rehab way easier compared to the ones that have been going on for months and months. And I think some of that is again kind of that tissue response to rest, or kind of that like excessive stress shielding, where a person has been like taking it easy for months and months, and tissue just gets softer and softer and more sensitive, and will have like less and less load capacity. And then you're kind of starting with tissue that's really deconditioned. And it just takes that much longer to kind of get back to a functional level.
Exactly. Yeah. Very well said.
So load it.
Yes. When you were humans, we're meant to be standing, and that, again, like Rob said, that it's like a spring. So it's meant to take load. So if you don't give it load and do complete rest, it's not going to get better. The issue is still going to be there. You just have to adapt the activity, and we'll talk about that as well, and modify things a little bit. So yeah, the body's meant to take load, so you got to keep giving it load. In no cases of this have I had to sit somebody down. It's always like trying to slow them down. I had one patient I'll never forget him. He had and he knew what he was doing wrong, but he still kept coming, not very frequently, but I think I treated him for on and off 9 or 10 months. But the thing is, he worked at a site in northern part of Alberta where he had to walk in steel-toe boots for 15 or 18 kilometers a day. He was a supervisor.
Oh.
So there was the problem, but you couldn't change it because you couldn't, they couldn't get him a golf cart, for instance. I'm get a bike if you can. So his problem was there. We just had to manage it. And then finally he had 2 months off work. And then we just we resolved the issue essentially. So sometimes it comes down to the job you cannot avoid because you need to make money. So you kind of have to manage things like that. So tough case. That was the most unique plantar fasciitis case I had. So yeah. And if we go through exercise, we can show you a few things to do. These aren't too difficult to perform at home. So if you've been managing this type of issue for quite some time, the pain's moderate, so it's not too heavy, then you can probably start with these exercises. So I want to make sure everyone can do it. If it's very severe, 8 or 9 out of 10, then call us or call your physio or your healthcare professional and just make sure there's nothing else going on, like a broken bone or something like that.
Like a tear in the fascia.
Yeah, you could have a tear in the fascia. So what we're going to show right now is safe to perform if, again, you have some tightness and some moderate pain. So you can try this stuff out. So we could start with some pretty basic stuff in terms of using a ball or an ice bottle. So you've seen ice bottle massage for this. So just take a water bottle, throw it in the freezer, freeze it, and then you can roll your foot out on it for 5 to 10 minutes at a time. I like to get right into the area that's sore, so the focal point that's sore, to get the ice on there as much as possible, just to be a little bit more aggressive with it. Another thing that's, again, very effective, I'm just going to twist the camera here and go down a bit, right to the foot level. So actually we could give this ball to Rob, so a very hard, small ball. You could even go smaller than this. So if this doesn't elicit too much, I don't want to say pain, but you can't find the spot with this, use a golf ball, a marble, something like that. I'll roll this to Rob's foot.
See if I can catch it.
So you have Rob rolling out his foot. So when he comes to a point that's tender, he will wait there until that pain, that sensation goes away. Things loosen up. Let's say it's been 20, 30 seconds. He goes to the next spot. With this one, I'd start away from the center of the pain. So if the focal point of the pain is back here, then maybe start a little bit further away from it. Take your time to work into it, because the input right in that tender spot could be quite a bit, quite heavy. So we'll do that for, let's say, 3 to 5 minutes on that side. If the other side's painful, do the other side as well. I think it's, again, even if it doesn't hurt, a good idea to try it out, see if it makes any improvements. Another one you could do is with the foot here. You could actually kind of bend it back, right? So bend your toes back, stretch that fascia out, right? Bend your ankle up. For me, I can feel it quite strongly. Rob will do it as well. And I can feel a little bit of a stretch in the arch here. Yeah. I'm not using my other foot because I have holes in my socks, so I don't want I don't want to. If
you're watching this, send Sunny socks.
It's not because, the income's affected. It's just I just wore the wrong socks, I guess. So
yeah,
the stretching.
Plantar fascia is most stretched with the ankle pulled back and with the toes extended. Yeah.
So you get a strong pull on that fascia. Hold 30 seconds to a minute. Repeat it a few times on each side. If you run a lot, good idea just to try this and then do your activity and see if there's any improvements. And then kind of what's good for you, what's not good for you. Those are pretty basic things to do while we're here, so we don't have to move around over and over again. So if you have a smooth floor at home, like tile or what else could you have? Hardwood floor, laminate, anything, linoleum, any smooth floor, right? So you put a towel on the ground, and then what you're going to do is towel scruncher. So trying to scrunch the towel. This is not a smooth surface, so I'm going to have a very hard time scrunching the towel. But if you bend your toes in, what's going to happen is eventually the towel is going to kind of bundle up. And then you can actually extend your toes and try to straighten out the towel. I'm trying to straighten it out, treating a bit. So boom, it's straight. And then you start again, scrunching it up. You could throw some like loonies around or marbles and actually pick them up as well, right? So grabbing it, picking it up, throwing it into a bucket, grabbing another thing into a bucket. I'd say grab stuff just because it's like a little bit more entertaining than using a towel, right? So if you're grabbing, you could even grab a towel, pick it up, and put it on the ground. That's going to strengthen the intrinsic muscles of the foot. So that last article I showed, that does show some improvement in pain management and things like that, and function. So not only pain, but also overall functioning. Yeah.
Yeah, and the muscles we're talking about are the intrinsics. So the muscles that begin and end in the foot. And like thinking back to like where the plantar fascia sits in that anatomy slide, those muscles they're going to be like a little bit deep to it, but they kind of like run in parallel.
Yeah.
So we're thinking that if they're functioning better, they're just going to provide more support to the plantar fascia.
Exactly.
Is the idea.
Yeah. So you can't truly build up the arch, but some of the arch is supported by muscles, so you can train to a certain extent that area. So those are effective exercises. Again, very basic, very easy to do, which that's why I like this area. Then those things like can be more effective than you think. It's always like people are like, oh, whatever, rolling around with the ball, whatever. And then they start doing it like, no, this is actually really effective. And then icing it too, or using that ice bottle and that other stretch we went through. There's another exercise that Rob does himself for his issue.
Yeah.
And we can show you that one next. And then any others that we can throw in as well. So
sounds good. Yeah. I can probably do it right here.
Yes, I will help you however you need.
You throw me the towel? Oh yeah, thanks. So we talked about how the plantar fascia is like most tension when the toes are extended and the ankle is it's kind of more flexed. So this is basically like very similar to a calf raise, but with a bit of padding to kind of keep my toes pulled back, and that's just going to allow for more tension through the plantar fascia. So it's and then you're going to dose it the same way as you would a calf raise. So you might choose to go like kind of lower repetitions and a bit heavier when you're kind of getting more towards kind of your like good function. You might choose to go a little bit like lighter to begin with, but yeah, that's all there is to it. You can go 2 foot, of course. I'm just showing 1 foot so that I'm not kind of blocking out my painful side. But yeah, that's the idea. You can also like use the towel the same way to kind of keep that toe position, and then just work basically like a long calf stretch in the same way to tension the plantar fascia like that.
Yeah.
Yeah.
Great exercise, Rob. You made that look good. So,
thanks.
Yeah, that's a few things you can do. Try it out. Yeah, take pictures of you doing it. I always ask to share the picture, like to put it on stories, but that's okay if you don't want to. People are shy. It's not as cool as like the handstand putting on a shirt challenge. I've seen a lot of that. I went from push-ups to that, so I don't know what's going to be next. Yeah. Any questions on Zoom or on Instagram Live?
I think with the stretching for the plantar fascia too, like whether it's the standing stretch or like the non-weight bearing kind of self stretch, I think like it looks like we're trying to lengthen that tissue, but I think a big part of that is more even just desensitizing it.
Yeah.
So I think that's where kind of that even short term you can get quite a bit of pain relief from that.
Mm-hmm.
And I think it probably has a lot to do with pain, which again we know is kind of that great black box.
Yeah, exactly.
But, yeah, and same with the rolling too. I think you're just kind of adding some stress, adding some load.
Okay, so Steven says nada, we're good on the Zoom end. I know this is a bit quicker today. Trying to like make it more efficient as well to leave more time for questions. So this might be an area that there's not too many questions just because it's not overly complex, but I think it ties into what we're doing here. So from a physio perspective, what symptoms would lead you to believe a client has a plantar fascia tear? Is management similar to fasciitis? And would you generally refer to their doc or an x-ray? Tear, sorry, correction, tear. I did read it as tear, so we're I assumed it wasn't T. That'd be some pretty gross foot T or something like that. So I've seen a couple of tears. One of them came to me with the ultrasound, so that was diagnosed beforehand. The other one I referred on. And with this case, again, it was very similar to like a normal plantar fasciitis. So this person came in with a similar complaint. Pain was a bit worse in the mornings, and then kind of eased up throughout the day. She was probably on the more significant end of pain, so she noticed pain with more activity as well. So she would walk for long periods and notice it get worse. So the things I noticed as a physio was after 2 weeks, it was actually a little bit worse, to be honest. Mm-hmm. So I showed her some techniques, and it wasn't overly aggressive. It's just the way it was. And again, sometimes people can get worse, but then it also tells you what's more likely going on. And then you can refer quickly to somebody who can do the image and see what's going on. So she kind of got worse as she did her own manual therapy at home. And then within 2 weeks, I'm like, something's just not right about this. Usually, again, there's some sort of relief or improvement. So then I gave her a management program for the week because I just didn't want to get too aggressive with her. And this was years ago. And so 3 weeks total, I made the referral to her physician to get some imaging done. And then she had an ultrasound done, and it showed a small tear in that area, which we just took a lot of steps back. And then I gave her a very gentle, so to speak, home program, just with stretching, not too much like ball release for a month or so. And then we started getting into the regular program. So yes, it was torn. It probably delayed the whole program by like a month or two, but at least we developed that right away, because a lot of the times this stuff's not resolved. People can have these issues for years, right? So I noticed that with that patient. What about you, Rob? Anyone?
Yeah, same thing. I think the ultrasound is the best way to kind of get a definitive answer there. I think tears will sometimes kind of present with a sudden mechanism.
Yeah.
Versus just kind of waking up with pain one day, but not always at the same time. Yeah. And then failure to respond to what we know works for like your regular plantar fasciitis.
Yeah. If it's like a chronic inflammation, it's not severely torn, like it's not structurally at risk, but when it has and hers is pretty large. So luckily she eventually had to get cortisone to manage the pain, and then we could actually get the results we wanted. And then discharge was relatively pain-free. So the other question was and other types of treatment like shockwave therapy and taping. So I looked at one for kinesiotaping, a systematic review. I didn't include it on here, but it showed no difference using taping. So they did like K-taping specific techniques versus like just sham taping. So just a random tape job of the foot. And there was no difference to that or a control group. So I do know, but even though there's no research that shows like very positive, like there's some articles that are positive, some that are negative. Those are the smaller studies. And then there's the meta-analysis or systematic review that shows no difference. So that's from the research side. From the clinical side, I have done taping once in a while, not too often, to be honest, for this area. And I notice people come back saying, oh yeah, it's better. But I think that's more so because of their self-management and their exercise that they do. I think if they would have still had those benefits, it might just give them like the courage to the comfort of walking on it and getting up and moving. I think it's more of a cue, right? So just like an ankle brace, for instance, like a soft brace isn't going to keep it stabilized. It's just going to give you the feedback to like, I feel safe, I should be moving. So versus shockwave, again, like I haven't worked with shockwave machines in anywhere I've worked before. So I know, again, different research articles show different things. That meta-analysis that showed non-invasive techniques, shockwave was included in one of the treatments. So it does show some benefit. I think it's not needed. If, like, let's say you're at a clinic that doesn't have the machine, or if it's just something you don't want to use, I don't think you have to use it. I just know shockwave is a bit more effective when it's more superficial. So from the studies that I've seen, like shockwave on lateral epicondylitis or plantar fasciitis, have shown some improvements versus like some deeper issues in the knee and shoulder is more questionable. Yeah, because have you had a shockwave at your old place?
Yeah, I've definitely seen one study that was supportive of shockwave for plantar fasciitis.
Yeah.
And it was like one treatment per week, 3 weeks, and then no more shockwave from there. Mm-hmm. So I think with shockwave, it's important not to go too far beyond that for any condition, probably, based on what I've seen.
Yeah.
But again, that's something that I regularly use.
I'd say if you have access to it, sure, try it. If the conservative, well, it's all conservative, but if your core physio stuff is not working, right? So if you do your education, self-management, exercise, still not getting where you want it, modify it, back off a bit, still not getting where you want, then maybe try something like shockwave or referral for cortisone or something like that. So yeah, taping, from what I find, doesn't show any improvements. Research side, clinically, I don't use taping too often for this.
I think like management wise too, like if you are going to opt for shockwave, like think about like the exercise and like the load management education as being like 90% of what's going to get you better. And the shockwave is like maybe something to give you like a little push that direction.
Yeah.
But if somebody was being treated and just receiving shockwave, I think that's,
it's like, it's one of those research
garbage, but I do.
You could use that. We could say whatever we want. We're old senile physio.
I don't offend anybody.
I think it's like one of those things where a lot of the articles show like a combined effect, and then it's hard to determine what is causing that. But I think mostly it's going to be, and this is where it's shown consistently, is the education and all that stuff. So shockwave, I know like more superficially, it is a bit more effective, but I don't think it's always needed if you don't have access to it. Totally. I think it's more of like if the certain things fail, then try it as another resource, right? So like needling, for example, if I do some treatment or an assessment with somebody and they start responding very well, needling might not be needed. Like acupuncture or dry needling, I wouldn't even do if they're managed by themselves. Perfect. Don't want to introduce anything else into that program, right? So good questions, very good, from physios. So
I think like taping wise too, like again, like the same way that you would kind of like manage that more chronic tendonitis, I think it's important early on to kind of like protect it a little bit, let it settle a bit, and then start building it from there. So I think if like the example of like your guy who couldn't not work, or that's like a lot of people, right? Like we have to be on our feet during the day.
Yeah.
So I think in cases where you can't like rest the tissue in the short term, then I think something like, you could try tape. Yeah. And I would also throw like footwear changes. Like a lot of people have success with like kind of a rocker sole with plantar fasciitis because it keeps the toe from going into full extension on your push off. Yeah. And even like an off the shelf orthotic. I think the big thing is like, try it, take some steps. If it feels better, it's probably good. If it doesn't, it's almost definitely not. So I think it's important to be sort of response-based there. So I think tape like can be a way in the short term to offload, to kind of get a foothold, but probably nothing beyond that.
Yeah, with that patient that couldn't stop working and had the pain for a prolonged period, I did use taping with him. He was out of town a lot, so I taught him how to tape it himself, and he used that as a management technique. So even with athletes that are pretty severely effective, I've taped them before comp or before their activity, and they've noticed some improvement. So for that little bit of difference, yes, I think it's effective. So, and then that's where the research, again, looks at all these studies, and you could have some people that are responding, but their data just shows it's not clinically significant or statistically significant. So, but to some people, that little bit of help is enough to continue their activity. Very good questions.
Yeah. So I'd say try it. If it feels good, like do it. Don't rely on it, but in the short term, and then wean off of it.
Yeah. And just like you mentioned, like use it as an adjunctive treatment. Just, the core things are getting done, and then just add these things on and see if they supplement the program. Any other questions? Well, Laura McNeil's on. She's actually started with one of her colleagues, a 5-minute physio. So they have a cool page in which they show different rehab techniques in a very like efficient and short way, so you don't have to spend an hour like you do with us and learn. But they show a very effective way of treating things. So check out their 5-minute physio page for sure. I was looking at it and I was like, this is awesome. I wish we thought of that. But we like to talk a long time about a few things. Any more questions about this? So the take-home message is, if caught early, it's very effective. Like, you can treat it pretty easily. And it's something that, for the most part, doesn't have to be managed with anything other than like physio or just self-management. We got to thank you. No problem, Laura. You're in BC now, which I'm jealous about because that's my home. So hopefully it's as nice as I remember. And then yesterday we were talking about Toronto and I was like, man. So yeah, it's very effective to treat. A lot of the times it doesn't require surgery. Most of the time it doesn't require surgery. Like, let's say compared to a shoulder, that could be a little bit more involved surgically. Yeah, and if you just stay active, it's better. So keep the tissue loaded. It likes being loaded, so keep it loaded to a certain extent, right? So that might just mean, then like we're going to discuss how to pull the reins on activity. Is if it gets worse, like we always discuss, then take it easy, right? So if you're running, I don't know, 10K and it's like a 9 out of 10, probably means you're doing too much, and then reduce that down and then see how it goes and kind of slowly progress your way up. And then that sometimes means to take a little bit of a break, but still walk and do stairs and things like that, still keep it loaded. And that's the activity modification, is just, if it gets worse while you do something, just take it a little bit easy.
Gradual loading. It's the answer to everything.
Yes. It makes so much sense, right? But and I'm guilty of the same thing where I'm like, okay, no, I'm not really hurt. I trick myself, do something. I'm like, Kate, now I'm hurt. That was dumb. And I've done it a few times, like my knee, my hip, my shoulder. Everyone's guilty of it, but you just have to really listen to your body. Sometimes you're like me, where I'm lazy and I don't want to do a certain activity, and then I talk myself out of it, but I still do it, and whatever, it's fine. Or it's like, no, I do that activity and I'm actually hurting. It's not an excuse. Then I take it easy and I save myself from a lot of pain. So we'll leave it for a few more minutes of questions. Yeah. And then give me poetry ideas, or just tell me to stop. So if you see our stories, like we do our good morning stories, we do like music and stuff like that. And then poetry is going to be a new segment, which all this stuff's going to be really difficult to continue when we're open again. But I'm actually like, it's my mandate to continue. So just to serenade and marinate Rob a little bit more, I'll read him sweet poetry. Yeah, so a few more minutes for questions, and yeah, give us ideas of more topics, because again, this is going to likely last a little while longer. So and then direct message me if you have questions about getting the links to all the videos. So I did set up a Google Drive that has every single video every day of what we've been doing. It is a good resource, I think, for people. So you can just pick on, if you don't want to learn about plantar fasciitis, you could pick the pain one with Brandon, or you could, if you don't know much about vestibular rehab, then click on the one with Rob. So they're all labeled and numbered. So feel free to have at it. Just message me for the link. I wish I were like had more than 10,000 followers, because I could just make a post and you could just click on it and it would take you there automatically. But we're not that cool. So no, we're cool. But yeah, so just make sure you let me know, message me whenever you want. I usually respond pretty quick. As in Pursuit of Motion responds quick. I'll leave it mysterious. You never know who you're getting. It's usually me right now, but oh, sorry for the people that just joined. We will have this recorded. I will post it on our story as well, so you can access it all day. Yeah. Anything to add, Rob?
Nothing to add. Any plans for
Rob does a lot of good baking, so I'm wondering if he's doing any baking today.
When I left, there was a loaf of bread in the oven. Like everyone, we're making bread.
Because he bought 20 bags of flour.
We're, yeah.
I got to get groceries, and I'm not looking forward to it.
You gonna mask up or no mask?
I'll mask up. I think so. Yeah, I think it's the right thing to do. Just in case if I got it, I don't want to be spreading it to anybody.
Grocery stores right now with all like the directional
Which
arrows and stuff like that.
Oh God.
Crazy.
Which I shouldn't have it because I don't interact with anybody. Rob's here once in a while while we take our precautions. Yeah. Yeah, and then even Safeway, I was driving by the other day and there was like a lineup around the whole store outside to get in, and that turned me off. And I'm like, I can't. I need my fruits and vegetables. That's all I like. I just don't. That's okay. That's a me problem. Don't worry about it.
Mm-hmm.
Don't worry about it, community. Yeah, no problem. Thank you for everyone for attending. If there's any questions, you feel free to message me directly. And then tomorrow's going to be recovery and sport and activity. So recovery is a big topic these days. So I think it'll be good to go through that. So Rob, we can patch you in too and talk about recovery, like how to do it, what to do, what does it mean? What does active recovery mean? It doesn't necessarily mean just sit in ice and hot baths. It's a lot of stretching. A lot of athletes have an active recovery day, which they're still doing like cardio. They're still doing stretching and stuff like that, taking care of things that might be adding up. So make sure to check that out. Yeah, so no problem. Thank you guys. And we'll see you next time. We'll see you tomorrow, hopefully. Spread the word. It's going to be interesting. Every day is interesting. Thursday is going to be pelvic floor. And then Friday, Rob will be back. And we're going to do probably just running on Fridays. Yeah, there you go. So yeah, we're going to do just, we'll keep it as running and stuff like that on Friday. Recovery is great. Thanks, Sonny. Yes, no problem, guys. Recovery is great. So we'll teach you techniques and maybe how to do it more efficiently. I don't want to say correctly because a lot of people do it the right way. So yes, thank you guys. And we'll see you, what is it? Tomorrow. I don't know what day of the week it Tuesday.
It's Tuesday.
Okay, all right. Okay. So we'll see you guys. We're checking off. We'll see you tomorrow. Bye guys.
Thanks for stopping by.
Peace out. Listen to my poetry later.
I was looking at like an ice bath study. It's pretty cool. It was so they had athletes like either do the ice bath or the like room temperature bath.
Yeah.
And like rate the recovery afterwards. An ice bath are like way better.
Yeah. Then
they had athletes do an ice bath, a room temperature bath, or a room temperature bath with a recovery serum that they put in it. And they didn't tell them what it was. They're just like, it's got the recovery serum in it. Yeah. But it was like green dish soap. And ice bath and dish soap both did the same. Fantastic. Room temperature water was like,
oh my God.
Yeah.
That's just going to make my topic tomorrow is going to be very difficult. It's going to be very difficult.
That's just one study, but they thought